said, my name is Justin Duncan. I serve as the CEO for actually a couple of ambulance districts in Missouri. My home base is Washington County, and then we have some joint power agreements for operations of Merrimack Ambulance District in Franklin County. And then we also have an agreement with our local community college where we lead their EMS education programs. And that'll all make sense why these things are important by the end, I promise. This is my first time presenting to a group such as you all. So if something doesn't make sense or we're talking in vernacular that is a question, please throw it in the chat and Doris will wrangle us together. Doris has been with us since the infancy of this project and projects honestly before. And so she's often my test subject on making sure that she understands things and can speak in the language of others. So she's my interpreter, that's how I call it. And she's welcome to pop in here if something doesn't make sense at all. So I want to talk about the backstory first. What is a paramedic or an EMT and kind of how we got here? MIH has been something that's been talked about for years and years across the country. And you may have heard it as community paramedicine or as wellness checks or as MIH. And it's very adapted based on the community and the needs. So we'll just kind of run through a little bit of a backstory and then how we stumbled on our project and our future plans and how really it can be replicated and how it's just good for patients. Well, hold on. Let's see. I was trying to click and it didn't go anywhere. Okay. So general perception of what we are in this business we call EMS. Everybody thinks of red lights and sirens and firing off to emergency calls and rushing people to the hospital. And that's just not realistic, honestly. We do, of course, take care of critically ill people, but more and more as we progress, we're becoming primary care. We just happen to do primary care in the streets. So EMS has been around since the 70s. So we're relatively in a very young organization when you talk about the healthcare spectrum. And really it was before the 70s, EMS was ran by funeral homes to where they loaded up the patient in the back of the hearse and they drove real fast to the hospital. And then they really made their money on the back end of things, literally. And if they didn't survive, then they would take them back to the funeral home. And so there was lots of two-way street trips back in the day. In the 1970s, EMS was developed under transportation, National Highway Transportation, as a response to people dying in car accidents. It was modeled originally off of military and wartime, and it's basic care. So my industry has been in what I would call an identity crisis since the beginning and where we fit. Originally, we were public safety, but we were the stepchildren of public safety because the fire department and law enforcement had been around forever. And they said, well, then you should really belong to hospitals. But we had not historically been accepted as healthcare. And so really, I kind of put us somewhere in the middle. We're hybrid. We do have a public safety element in that we have vehicles and we go all over the place. But truly, we're a healthcare agency and becoming more and more a healthcare agency. We just happen to treat people in their living rooms on the side of the highway, in public spaces. But really, the business is evolving greatly in the last few years. Sadly, CMS views us as a transportation service. And historically, if we look back at the 70s and the 80s, that was the grand majority of what my business did is you call, we haul. And now we're offering and rendering care in patients' living rooms. We're starting treatments for critically ill patients at bedside. And transportation is just a small piece of what we do. And, I don't know if people know it or not, but there was this little thing called a global pandemic that hit last March, and our business really evolved, and that's what kind of got this project started. From a licensure standpoint, our entry level is an EMT. I think it's a bridge kind of between sits in the middle of a CNA and an LPN. It is a semester course, but it's a heavy semester course. They're technician based. Meaning I see this and I do that. Patient is bleeding, apply direct pressure, lift arm, limited care or limited education on the physiology of disease processes, basic care. This was the original level of ambulance care, and believe it or not, it was a step up. The original, before that, it was advanced first aid, and before that, it was simply ambulance drivers, and sometimes you had an attendant that may or may not have education. And so EMT level of education was a very, it was big. This was the first time that they could clear an airway obstruction, administer oxygen outside of the hospital. CPR was an up and coming thing, but they provided no advanced treatment. We still use EMTs today. This is entry into our business. Hospitals use EMTs, clinics use EMTs as patient care technicians. And then there's this thing called a paramedic. And if any of you remember watching Johnny and Roy on Emergency, that was what we were based upon. It was a fight to take care into the field. It was different across the country, but Johnny and Roy absolutely represent the early paramedics in Los Angeles County. And so if you park in your brain somewhere that paramedics were designed as physician extenders. And so in the old days, the paramedics would get to the scene, they would assess their patient, they would hook them up to cardiac monitors, and they'd get on the phone with Rampart and go, okay, Dr. Brackett, what do I do? I see this, I'm doing these things. And he would say, start an IV, draw some blood, give these drugs, transport, so on and so forth. The education still was technician-based, very much call in and receive orders for patient care. And as we have progressed, that model just simply was not maintainable. And we have moved to what I call a pre-hospital clinician. So education today is very, very, very similar to an associate's degree nurse. It does vary by program, and that's one of our downfalls is that we're nationally, all education programs for paramedic are nationally recognized, and we're trying to get more standards. But the timelines still vary across programs, and we're still fighting. And I don't know my background here, and I'm seeing some names on there that probably remember the days of a certificate nurse before you had to have an associate's degree to get your RN. That was a thing back in the day. Now entry-level requirements are an associate's degree, and we're in that fight currently to make paramedics an entry-level associate. When you look at the education, it's there, the hours are there, the credits are there. It's getting folks to recognize that having education tied to your licensure is a good thing. Paramedics in the state of Missouri are licensed. They hold a license to practice that is driven by a medical director. And this is key as we move forward, that you have to have a physician, I'm going to use collaborator, similar to what our nurse practice do, similar to what our PAs do, that you have to have that medical direction key to be a part of it. Now, where my business is weird is every state is different. EMS in Okay, I think I'm back, Doris.
Awesome. I hear you. Yes.
Okay.
I've been filling people in on chat. I explained that Washington County,
Sorry.
Their service for audio and internet is challenging. That's one of your challenges. So
yeah, we're a little in the sticks here.
Yeah. So just pick up where you left off.
All right. Again, I apologize. So medical direction is key for this project to work. And that should make sense as we progress here just a little bit. The paramedic education switches us from a technician-based program to a clinician, high focus on anatomy, physiology, micro disease processes. Again, that very same background that we give to our nurses with the heavy sciences focus. Whether those individual courses are required or it's a part of the paramedic program itself, that is what it is. The deciding high level is we teach critical thinking and critical action to assess, make a plan, do, and evaluate. Remember that these folks, guys and gals, have limited diagnostic capabilities in the field, but that is progressing as things become more and more mobile, and we'll discuss as we move on. Their skill set supports intubation and airway management, medication administration to facilitate airway management, commonly referred to as rapid sequence or delayed sequence intubation, CPAP, BiPAP through basic ventilator initiation in the field, of course, circulation support, and really anything above. The key in Missouri is paramedics don't have a scope of practice because they are licensed as a physician extender, and therefore we can be very specific to the needs of the community in the emergent setting and the non-emergent setting. And so keep in mind the needs of Washington County, 55 miles from the St. Louis metro area, are very different than super rural Missouri. I think of Houston, Missouri, where they're a long ways from nothing, or downtown St. Louis. We all have the same license, but the needs are different. And in Missouri, we've embraced diversity and have allowed for such. Similar to our nurse friends, once they get that initial licensure as a paramedic, there are add-ons, just like nursing does. And, you can transition to a bachelor's degree in health sciences, similar to, your ADN to your BSN route for our nursing friends. And then we do what we call add-on endorsements or board certifications. Historically, the most common one referred to as critical care transport. And this is key because we take them to the next level. The licensure, the certification is similar to a critical care nurse or a flight nurse. It requires additional education and clinical time and really takes us from the emergent care, ER care, to more ICU care, and tying in invasive lines, balloon pump use, ECMOs, mass transfusion. Think of taking a sick person from one hospital to the next, whether it's in the urban or the suburban or the rural setting. And then most recently, we have this thing called the community paramedic or mobile integrated healthcare add-on. And where my industry said, hey, if we're going to start doing some of these things that we call home visits and treating the whole patient in their living room and plus minus taking them to the hospital, we probably need to train them more around, like things that home healthcare nurses do and things that our friends on a med-surg floor do, because historically we teach them about emergency care and ICU care. And this is paramount when we talk about, the education component. And honestly, when we built this and, I took one of my nurse friends from the floor and I said, okay, teach a paramedic to be a floor nurse. What do they need to do? What don't we teach them in paramedic school that, you take care of every day on the med-surg floor, or when you're sending people home and educating them? Things that come to mind to me are wound vacs and wound care and ostomies and J tubes and peg tubes. We don't deal with those historically and manage them. So really, when you break down what we do, it really depends on the system that they work in. 911 is probably less than 50% of what we do when you really think about it, the true emergency work. And just because they call 911 doesn't mean that it's an emergency. In the United States of America and in Missouri specifically, outside of a global pandemic, if somebody calls 911 with a stubbed toe, we take them to the emergency room. If they call 911 with a toothache, we take them to the emergency room. Prior to the pandemic, the only destination that a emergency ambulance, once 911 was called, the only destination an ambulance could go to was an emergency department. But when we think about what paramedics do every day, they start lines, they draw blood, we give IM and sub-Q injections, we administer meds and blood products. We do blood culture draws for sepsis patients. We have invasive line monitoring. Some newer things that we do are carrying iStats in vehicles to be able to do point of care lactates and point of care blood analysis emergently and non-emergently. We create care plans. We just don't call them care plans. Ultrasound is something that's up and coming in my business. Every one of my ambulances has ultrasound, but we got ultrasound for emergent use, doing fast exams, looking for major bleeding sources, for Dopplering for pulses, line placement, and now we're transitioning that to non-emergent work. We do field diagnosis of patients with limited diagnostic tools, and then we create care plans and destinations for our patients. So I know you didn't join us to hear about an education lesson on what a paramedic is, but I think it's important to understand as we move into what is a mobile integrated healthcare system. It's very diverse. It is very community focused. It's caring for the whole patient and not necessarily taking them to an emergency room. It is paramedic driven. with additional education. And remember, I said, paramedics were designed as physician extenders. There's quite a bit of feedback in my headset, so if we can mute, please, I'd appreciate it. So we are physician extenders, and we are just now embracing in MIH that primary care level of an extender to a NP, a PA, or a primary care doc, absent of or instead of an ER and ICU physician. MIH is very unique, as I said. The needs of downtown St. Louis or our bigger cities, they focus their MIH programs a lot on readmissions and bounce backs. If you look at some communities that don't have hospitals, they're doing minimal primary care and then referring to clinics. Our vision of MIH was management and controlled of uncontrolled conditions. If Washington County is a little bit unhealthy compared to the rest of the free world, and I'm saying that as sarcastic as completely possible, I tell everybody we're in the top 10. We're in the top list, not in the good list, but heart disease and diabetes are pretty high up there. COPD and CHF patients, and we have a very uncontrolled, non-compliant population. So the idea was when we formed this, the surrounding the pandemic, we were worried that our hospitals were going to be overflowing, and we told people not to go to the hospital. But then we realized that people are still sick out there, and we decided that we can fill those gaps and help manage these patients with a good medical direction, and you have to have a good clinic partner, but we can do it. So I've touched a little bit on our COVID here. So one thing in Washington County is we're a bit unique in multiple ways. When COVID hit, we all sat at the table and went, what are we going to do? And I'm finding the more that I get out and about, that is very unique. And when I said we came to the proverbial table, it was the ambulance district, public health, our rural clinics, our hospital, communication center. And we said, how are we going to handle these patients? We know that our patients are not super compliant here. What are we going to do with them? Well, people got scared. They didn't go to the hospital. And just like you all know who your regular patients are, whether you're in a clinic or in a hospital setting, we also knew who our regular patients were. And we stopped seeing them. And we stopped seeing the people who presented to clinic every week. We stopped seeing the people who used the emergency room as primary care. We stopped seeing the people from calling 911. Our volumes tanked. And we went, all these people didn't just magically get better. So we decided to start this thing called wellness checks for missed appointments and people that we were worried about. And we just told our clinics, we know that you all have seen your patient volumes decline. If you have a sick person you're worried about, give us a holler. And we told our public health department, as more and more positives came in, we have a small public health department with 3 nurses and a few technicians and office staff. If you've got a family full of sick people, we'll go check on them. We decided that we had the ability throughout this process to do mobile COVID testing in people's homes versus taking, the whole family in a car and exposing them to a ton of people. We could go to their house and we could do some swabbing. We noticed that patients were missing their routine lab draws if they were on Coumadin, and they needed their PPI&R draws. And we went and just did their draws in their living room. And we identified some people through everyone's concern that likely would have had a very poor outcome. There's a couple of patients that come specifically to mind that we found. We convinced that, yes, COVID's scary, but you're going to stay home and die. It's time to go, that were ICU admit. We also didn't realize that we would be treating the whole patient. And so, there was a patient that we went and checked on that hadn't been seen in several days, in several appointments for his diabetic problems. But we found that he had an abscessed tooth and was weak, and we were able to get prescriptions called in and set him up with emergent dental visit, a few days later. So we really just kind of rolled with the punches and went through things. Then vaccines became a thing, and this is a picture of my garage, our building, and vaccines came out this fall and this winter when it really wasn't the best weather outside, and we started doing drive-through clinics. None of this would have been possible without great partnerships and coming to the table ahead of time saying, we know that we're going to need help. No one system can do this. And, you can't take the volume of giving vaccinations to 16,000 different people, which was our running total. And you can't do that in clinic office visits and in public health offices that are small. So we banded together and we put shots in arms. And it was a really very interesting experience, and not one that we would have thought was a primary focus of our MIH program. But the goal here is to treat the whole patient and keep them healthy. And vaccinations just got added to the list. So we started doing this with no funding. And I'm using air quotes here, and I hate not being able to see folks and read their faces, but we did this out of the kindness of our heart because it was the right thing to do. It was good for patients. It was good for our community. It's kind of cliche to say, but the folks out there, they saved some lives in this process. And so we had an opportunity with our dear friends at Great Minds Health Center on a diabetic project. They got some seed money on a diabetic project, and it was around taking the uncontrolled HealthNet patients, uncontrolled diabetics, and making them better. Well, the compliance rate was not good, getting them to come into clinic. And so I'm very grateful to have become good friends and good partners with Great Minds Health Center. I talk often, COVID has been horrible. It is still horrible in my area. We are losing patients. We are seeing huge numbers needing intensive care, and not just COVID patients, but across the board. And we don't have homes for them. My rural critical access hospital is boarding ICU patients all the time. We've been boarding vented patients. There have been some blessings from COVID, as I've said, and the biggest blessing is creating these partnerships. So Great Minds and I sat down and said, these people are not showing up to the clinic. We know that they're not managing their disease process. Can we shift this project, this grant funding that they had, to incorporate the ambulance dudes and call it our mobile integrated healthcare network? And that's exactly what we did. And it was sold to the Missouri Primary Care Association that, yeah, we're healthcare and we can do it. So our initial project just tagged on to theirs. We became a subcontractor of Great Minds Health Center. We did all the background paperwork and BAA, and we sat down with a very simple, what do we need to keep these people from A, dying, and 2, can we make them a little bit better? So what we came up with was our friends at Great Minds utilizing their community health worker, which now I think is they're good as gold to make this function. And they would simply schedule an appointment. We sat down with the primary care medical director at Great Minds and said, what do you want from them? And we said, well, we need to draw their blood, and we need to do an A1C, and we need to do some basic labs, and we need to be able to chart and, do assessments and such. And then it progressed to, well, we're going into people's homes. We should do a risk assessment of their home, their safety assessments. Do they have access to what they need, et cetera, et cetera. And then we need to chart it. And then we set up a telehealth visit. So telehealth became, everybody I'm sure is using telehealth. And so we call it telehealth on steroids, because you actually have a clinician at bedside or at recliner side or at kitchen table side doing an assessment. And paramedics do this every single day, just in the emergent setting. So we have the tools to do it. All of our cardiac monitors do multi-lead EKGs. Well, instead of uploading it to a hospital's chart, I upload it to a clinic chart. We draw blood every single day. Well, instead of taking back all the labs, we got a portable A1C machine, and we're able to run their A1C right in their living room. And then we can draw labs based on either the general order of a CBC and a CMP as their routine lab draws. And then after the telehealth visit, the paramedic is able to go, hi, Dr. Pearson. I know that we're here for a diabetic home visit, but we noticed that the patient has this new decube, and would you like us to culture it? Or they have a new onset of generalized weakness. Do you want any add-on labs? Or they're not compliant with this medication. And we treat the whole patient, and we can get extra labs orders for basically anything. while we're at the bedside and treat that whole patient. And it really comes down to the facilitation of a telehealth visit. And one thing to keep in mind, if you go back and you look, we didn't want to take work away from home health, but we also acknowledge that there's a lot of people that don't qualify for home health, or they qualify for limited home health. And we just wanted to fill the gap for these patients. And, if you look back over studies, my folks are invited into people's homes, which is often considered a very sacred place, on the worst day of their life. So think about a paramedic, think about your own experiences. Think about, a paramedic getting called for a child who's not breathing, and those parents feel comfortable to hand over their baby to a complete stranger. That is a very sacred thing. It's something that we are very honored to be a part of. And so we're welcomed into people's homes on what is probably the worst day of their life. And if you look at the psychology of it, they're more apt to welcome us into their home for routine things, because they're willing to hand us their child in an effort to save their life. So all of our patients have enjoyed the visit. And there's some sociology to it and some psychology. So this was our initial very small team. We have Dr. Pearson in the white coat, who was a paramedic a long time ago in a land far, far away. And so having him understand our brain helps a ton. And then he can help educate his providers inside the clinic on, this is what these guys do every day. This is their abilities in the critical patients. This is how we can trust them with our routine patient care. That is Rebecca Jones. She's the COO of Great Minds Health Center. Myself standing there in the middle. And then Tori, she's the real rock star of this program. She is our sole community health worker when we got this program working, and we truly underestimated their importance and their wealth. And I can't speak highly enough for it. Greg's the CEO, and the tall guy on the corner, that's Tony. He was our sole initial community paramedic for this program when we got started, and just a very small team got us going. So, of course, we didn't knock it out of the park on day one. Some very clear lessons learned are these CHWs are the golden ticket. I call them our gatekeepers. We call them mission control. They're the ones that not only set up the appointment, but when Tony and team call back, they go, hey, Tori, we need to loop Mrs. Smith in with cardiology, or I'm going to do a bedside echo. Can we have that sent off to so-and-so because they're, I'm concerned about their EKG. And then we have stopping points. At any time if something's identified as an emergent issue by anybody involved, they go to the emergency room. But the grand majority of these, 99% of the time, we are adjusting meds. We are getting people who don't historically have access to primary care, and we're treating these patients as a whole. We did not anticipate the level of difficulty to make charting software talk. Heaven forbid that in the year 2021, that everybody's EMRs be able to talk to each other, and so that we can share data back and forth. That, of course, is not a problem, or not happening, and an issue that we're trying to work through present day. And that the clinic providers and the community paramedics need to form a special bond, just like the paramedics have a special bond with their home ERs and their home ER physicians. The more that they become comfortable with each other, the more that can be done in the home. The whole patient care, I keep harping on that, but I can't tell you how many times you go for a diabetic visit and it turns into a behavioral health referral, or it turns into a resource assistance. We do med reconciliation. How many of your patients have primary care, or they don't have primary care, and they see a nephrologist, and they see a cardiologist, and they see a neurologist, and they don't all talk to each other? And so with those med reconciliations, you see patients being over medicated or double medicated, and there's those cross checks and those safety things can happen in the home versus getting them into primary care. The barriers that we heard for folks are, one, they're just scared to go to the doctor because of COVID and all their pre-existings, and they were scared to die. We had the patients who said, oh, I'm fine, I don't need to go. We had transportation issues. And then we had people that couldn't afford their medicines. And so the community paramedic is able to then loop back to the CHWs to find those resources for these people. And ultimately, if they can't get out, we bring it to them. And that's just how our program works. We had some early results. We did this for initially, we looked at 1 quarter and the results were great. Every patient that we touched, we saw better benchmarks. At the end of the project year, we saw the same trends, and I was flabbergasted when we blindly pulled results. And the project, for every patient that we touched, we reduced their ED visits by 100%, meaning 0 patients bounced back that enrolled in the program, that stayed in the program and followed the rules. We had about 21 of those that really stuck with us through that initial period. Every patient showed a reduction in their A1C. Every patient showed med compliance increase. Every patient showed follow-up care, and all of them wanted to keep their in-home care. 0 patients called 911. It resulted in 0 ED visits and 0 admission. So in my brain, that is goal achieved. We don't want our diabetic to become non-compliant and wind up in diabetic ketoacidosis and admitted to the ICU. That ultimately, in a global pandemic, there's not beds for them right now, or the beds are very limited. They're at a premium. And why on earth would we not just manage their process to the best of our abilities to prevent those? One thing also is we track patient satisfaction, which also showed 100% positive results. Some of the handwritten notes that people said, they'd given up on life, that they were just accepting that they were going to die from their disease process. They couldn't manage it, and they were immensely grateful for simple things. We helped people get onto, grant billing and balance billing just to keep their electricity on, so that they could get things flowing, get them access to their medications. So then we've moved on, and we were ultimately awarded a grant through HRSA, and Doris has been a partner on this and very, very definitely heavily involved in taking our ideas and putting them on paper and selling it. And so we took the model that we did with our diabetic friends, and we said we can outreach our county, because we have with regards to heart disease, we have a huge population of heart disease patients in our county. And it shifted from the Great Minds patients that were uncontrolled diabetics, and now we can target high utilizers. When we say high utilizers, in my business, we call them our frequent flyers. We call them our friends that we are involved in their lives as their primary care providers. And when I say people call us because they can't get their oxygen concentrator to work, or they don't know which medicine to take, or to check their blood pressure, I'm not joking. Those are all 911 calls, emergency calls for service that I have personally attended to. I am a paramedic by trade, although I've gone to the dark side, as I have said, to the administration side. And I still treat patients out there every once in a while. But I have taken care of every one of those patients that have called for what we call our minor illnesses. So our goal with this grant was to expand and really solidify our MIH network here, reduce 911 use, emergency department use, ICU any admission, and to get more community paramedics out there. Part of it is education, for which we have 13 current critical care paramedics, which is our baseline required knowledge to get in to the community education program. And 13 are currently enrolled in a program that we were able to build through our partnership with Mineral Area College. Again, we wanted to do the coordinated telehealth visit just for our CARDS patients. And heart disease is broad, uncontrolled hypertension, previous MI, bypass patients, post-cath patients, CHF patients, they all can be categorized under that umbrella. And so we developed our initial visit plan, and with basic lab values, get an EKG for baseline, or if there's already one, to compare and trend changes. We have partnership with cardiology for outside review, outside of the paramedic, the primary care physician. The ability, as I mentioned earlier, for in-home echoes to be sent to CARDS for review, all with positive results. That's the nice thing, is our physicians like the quality. They like the competency. We do bedside echoes in the emergent world all the time. Think of a post-cardiac arrest patient. We throw the probe on their left ventricle to decide what medicines to give them. Those things paramedics do every day. or before we pronounce a patient that was in cardiac arrest, we throw a probe on their chest and do echoes. Now we're just transitioning it to the non-emergent setting and getting our cardiology friends to consult and to like it and like the quality. Medication reconciliation was something that we we underscored the importance thereof and did not realize the number of patients who can't manage their own medications, who are prescribed multiple medications from different providers that don't talk. And a lot of this comes down to targeting the patients who do not have primary care and getting them primary care as that, quote, home base, end quote, physician or provider that is seeing the patient through the hands and the eyes of the paramedic on the other side of the team. Part of our network was bringing in the community college, and that was extremely important. And in a hybrid format, and we're proud of building that with our friends at Mineral Area College. We are looking at, we're not looking at, we wrote another opportunity. Well, Doris wrote another opportunity. We fed her the information and she made us sound awesome here. And it's around the CDC and the COVID pandemic. And, you know, worth mentioning through all of this, my team has given shots in people's homes. The people that were reluctant, we're doing in-home education. We're swabbing people in their homes still today. Our compliance rate in this county, last poll was 25%. I heard that we're up to maybe 30%. And we're giving shots in clinics. And I mean, you can call my building right now and say, okay, I'm ready for a shot. I can't make it out. We're doing after hours vaccines and in-home vaccinations. And I mean, we're now starting to talk about booster shots and our plans as we're experiencing a surge here and really not looking forward to the fall. So the underappreciated initially community health workers was the focus of this opportunity. And we really realized how they are amazing patient navigators. And that is what has really helped bridge the gap. And so we decided we need to make our community paramedics CHWs as well, so they can start to learn the process and the background thing. And then we need more CHWs in mission control. As the program grows and we continue to see more and more patients, we need more and more folks back at home base that have the ability to help us navigate and reroute patients for different surfaces. And our big partner adding in here is our public health friends. So right now, a letter goes out when they have any COVID positive patients. They send them out instructions on quarantine and resources and, resources in the community as far as clinics that patients can go to. And then we also tie in, hey, we have this thing called mobile integrated healthcare. If you can't get out, don't want to get out, we can bring services to you. So our goal as we move forward is growing the CP skill set, adding in that CHW education to make them the more well-rounded pre-hospital clinician, and increase the number of CHWs that are in facility from a navigator standpoint. And this is just an example that we're sending out with our patients on our, we can send you an MIH clinician, we can facilitate telehealth visits, we can do in-home COVID vaccines as well as swabs, et cetera, et cetera. And it's great. The future piece that we're missing out on and what we're trying to, everything's pre-scheduled right now. Everything is pre-scheduled. Mrs. Smith, we're seeing her on Tuesday at 9. We figured out drive time. I have a 760 square mile county with more cedar trees than people. So travel time in between, trying to narrow it down and schedule them in groups or clusters close to each other. The next vision is to triage low acuity 911 calls to a community paramedic. There are precedents for those throughout the country. And I look at it as if we can triage it, I just want my blood pressure checked. I can keep a 911 ambulance in service for the next emergency. Whereas today, if they're tied up on that and emergency arrives, we're sending a unit from a further away place. Or if the ambulance arrives and it's more routine care, they can dispatch a community paramedic and free up that ambulance for the next emergency. And then there has been some precedents during the pandemic with alternate destination from a 911 call. and not necessarily a treat and transport by ambulance to say a clinic, but more a community paramedic is called, relieves the ambulance, does an initial visit, and then a referral to primary care, a referral to a clinic, et cetera, et cetera. There are things on the national level that are being discussed, but what I have to remind people is I told you my business is based around treat and transport. And so when we do not take a patient to the hospital, we receive $0 from our insurance companies, and we don't get blood from turnips. With billing patients directly, you get nothing out of them. That's just the simple reality. And so we're trying to prove concept. I can prove concept with patient satisfaction. I can prove concept with patient outcomes. And now it's tying it into the money side. And that's where Doris and her team have just been fantastic in looking at how we can change. We also have noted before we would send our community paramedic in an ambulance, because that's our office, and people would be, oh my gosh, why is the ambulance at Mrs. Smith's house for an hour and a half? What are they doing out there? They've been out there forever. So we found some grant dollars, and we built our MIH1, which is an SUV, and it has outfitted in it. When you pop that hatch, a big compartment rolls out, and there's our A1C machine. There's our COVID swab machine. There's a refrigerator in case we draw labs and they need to be cooled. Next on the list is to get an iStat to be able to do these labs, routine labs at bedside from a point of care standpoint. And there's a plethora of options. And so it's more discreet and incognito than having an ambulance sitting out front in someone's yard and having every nosy neighbor ask what's going on. So of course, right now we're grant funded, right? That's how we're surviving. That's how we're doing these programs. There is reimbursement right now for telehealth for our friends at the FQ, but we don't know what the future holds. So what we're trying to prove in my industry, there's a group here in Missouri who has pitched pilot projects and got the attention of MoHealthNet. Now, unfortunately, we were doing this before our global pandemic, going, let us prove concept, let us work with our high utilizers, let us show that this not only is better for patients, but it saves the system money. And then COVID hit. And then now there's structure changes. Well, actually, next week we get to pitch our idea again, and they're extremely interested. And they're interested from a cost saving standpoint, which we'll get to here in a second. There's currently, MoHealthNet does treat no transport reimbursement for a 911 call only to the tune of $150. I cannot pre-schedule that. That has to be Mrs. Smith calls 911 and then is ultimately not transported to the hospital after we render treatment. The most commonly thought of here is a diabetic who took a little too much insulin. We start an IV, we give them some dextrose, they wake up, we make them a sandwich, we do some in-home education. That $150 doesn't even cover the supplies, and that is MoHealthNet only. There's some pilot projects through CMS. It's called ET3, but it's still in the testing phase and the model phase. And so we're really advocating as an industry, and this is one of those blessings I call for COVID. We have had taken on additional roles that we historically didn't. And so we're saying, if we're good enough to go to someone's house today during a global pandemic and go, you're not sick enough to go to the hospital, and arrange for you to go to a clinic or arrange for you to have non-emergent care that is now supported on an emergency basis because of hospitals are filling up. If we're good enough to do that in a global pandemic, also there's no reimbursement for it. Let's tie that together. Then we should be good to do it in non-global pandemic times, and let's tie a little bit of funding to it. So the big proposal is we transport people, yes, but we also care for them. So right now we are not reimbursed for supplies. We are reimbursed as a bundle charge for a level of service and mileage. So our goal is to be paid based on the level of service provided by the clinician and what we actually do for the patient, and then transport as a secondary opportunity if it is a patient that's transported. We also need telehealth to remain permanent funding for our clinics so that we can continue to continue the model and take care of these patients in their home. Our goals have really remained unchanged, that we accept that sick people don't manage their conditions well. the healthcare system in the United States in 2021 is difficult to navigate. And the elderly generation and even the not elderly generation have a hard time to navigate the system. Sick people, they just give up and they stop caring at times, and they have poor follow through. We have low rates of compliance in our chronically ill. Every single day in the United States of America, emergency departments are utilized for primary care. That is a known fact. Should be a surprise to nobody. And my folks, they render primary care every day in an ambulance. Like I said, if you really calculated out 25 to 50% of ambulance use at best is emergent care. Do I still have you, Doris? My screen went crazy.
Yes.
Okay, good.
So can you see your screen now? Is it
hold on.
not sharing?
I can see my screen is
Try and
it not up for you guys?
No, we can't see it. So try resharing it.
Okay, hold on. I think this is Zoom's way of saying you're talking too much, Justin.
And I'll let you know you've got about 10 minutes. So I don't know how many more slides you have. I can't remember. So
yeah, my Zoom is sitting here and just spinning and spinning. So I think I'm going to have to talk through this while it tries to load for the sake of time.
Okay.
Which
I know you were leaving
sad.
Yeah. Go ahead. We're
talking now about cost saving assumptions. And my Zoom is just
Is your
frozen.
presentation the same as what I reviewed last? Because I could bring it up. Or did you make edits?
Yeah, I made a couple of edits, but I've got it right here. Let me shoot it to you real quick.
And then I'll share it. And then you can continue to talk.
I'm sorry about this, guys.
It's not your fault. It's just, broadband is what it is. And making the best of
the barrier
we have.
Right. I mean, while this is sharing, that is one of our biggest barriers. We have mobile hotspots through Verizon and First Health Net system. And even with, and they're supposed to be higher power. Okay, that's headed your way, Doris.
Okay. Just go ahead and continue to talk.
Sure. So that access to good internet, these people don't have it at their homes because it's not available mostly. And so we have to bring that with us. That was an early lesson learned. So when I'm talking about the cost saving potentials next. When we started our pilot project and our presentations to our friends at MoHealthNet, we had to make some assumptions and then get those assumptions, approved would be the right word, for what average reimbursements are. And of course, these are a little different, but for some baseline numbers, it's accepted that in Missouri, a Medicaid reimbursement for the average ambulance transport is at $400. The average reimbursement for an ED visit is just shy of $1,000, and average admission is $11,000. Now, of course, that is very subjective because that's not necessarily an ICU stay. That's not necessarily. We just took some middle of the road basic assumptions here for discussion. Doris, did you get the presentation?
No, I think something's wrong with your internet. So I was I'm going to pull up my presentation that I have. And if there are things that are different, you can just talk through it. How's that?
That's great. I lost Zoom completely on my computer. So it says I'm a post attendee now.
Okay.
And so
is everybody else still on? Can people unmute and let me know if you're able to hear us? I want to make sure it's not okay.
Yep.
I'm going to just bear with us. Justin, you just keep talking from your regular presentation. I'm going to pull up your presentation. I've got it pulled up. I just need to get you to the right page before. I haven't shared it yet, but I will.
So I'm going to start talking. So we pulled 3 patients for our HRSA grant, and I don't think that people realize how often we see these patients. So we pulled 3 of our top utilizers, 3 of our highest frequent flyers, as we'll call them, from a cardiac patient standpoint. And so we fondly named them. Well, the first is patient B, 58-year-old patient who lives in public housing, and she has a cardiac history. has no primary care physician, utilized local emergency department as primary care, and in calendar year 2019 had 92 emergency calls for service, with 63 of those resulting in an ambulance transport. In a retrospective look, 15% of those actually met medical necessity for ambulance transport, which means we got paid for 15% of those visits. Just because they go by ambulance doesn't mean that you get paid for them, but you have to take them to the hospital. We don't have the right to tell people no. We take them to the hospital, and you just eat it. It was identified that roughly 85% of those met primary care needs, but still emergency ambulance and hospital were utilized. Our second friend was patient M, with an extensive cardiac history, multiple cardiac caths, is a post-CABG or open heart surgery patient, poorly manages her hypertension, and she demands transport to a facility that's 45 miles away, because that's where her, and I'm using air quotes, cardiologist is located, even if the call doesn't warrant an immediate cardiac evaluation. She could call for, I just don't feel good, and after life threats have been ruled out, demands transport out quite a ways away. In 2019, we had 62 emergency calls with 55 transports, and in retrospective, 90% didn't meet medical necessity. And then Mrs. O. Mrs. O is morbidly obese, uncontrolled hypertension, COPD, coronary artery disease. She is when I say morbidly obese, it requires 2 ambulances in the fire department to be able to move her. And she is known very, very well throughout our community. And a lot of the times she accesses the system is due to isolation and being lonely. And we are her primary care providers. She had 135 transports in a 36-month period. And we have to remember, we not only take her to the hospital, but due to morbidly obese, we take her back from the hospital as well. So Mrs. O is kind of what we used as our benchmark from some cost analysis standpoint, with her trip to the hospital and her reimbursement and her ED visit. She's looking at $70,000 in total cost to the system. So when we looked at Medicaid potential cost savings, we did some assumptions that MIH is not going to be free. Right now, we're getting some money from some grants. We're going to tag it to patients. There's definitely some supplies. And so we came up with $2,700 and some change for an average program cost for one of these patients to be able to track them and accept that some are going to require quarterly visits, some are going to require monthly visits, some might need weekly visits early on and then tag off. And so we look around those high utilizers, and we kind of came up with, there's about 450 people that we can work with. When we pull our real patients, the 3 that we kind of talked about, and we're, even if we tie an assumption of about a 30% admission rate, we're looking at a cost to the system over a multi-year period of $1.7 million. And so we said, if we can even reduce their use of the emergency system by 25%, we can hugely affect the bottom line savings. And it's not just about savings, it's about improving their quality of life, managing their systems, and making them overall improving their satisfaction of being a part of this world. But when you look at the savings and the potential of, if we take our high utilizers and just go with 10 transports a year, that's 10 ER visits, and even following our 30% admission rate, you're looking at a cost to just the Mo Health Net system or Medicaid system. And these aren't actual costs. These are just average reimbursements, which are probably low. You're looking at a $63 million cost to the system. So when we're talking about reduction of 25% or 50%, we're in the millions of dollars here. So the current reality from a baseline is about a $63 million cost to the system. And if you can simply reduce it by 25%, which we think is conservative, to a 50% reduction, I mean, those are millions upon millions of dollars of savings to the system. So from a high level, MIH is good for patients. It saves the system money. Every patient that we've encountered has admitted a better quality of life. They enjoy the services. They admit to being non-compliant for multiple reasons, not having access to transportation, being scared, not going. And so the patients like it. So our system is, it's good for patients, or our stance is it's good for patients. It saves folks money. Why not? And then we really have to advocate for long-term sustainability through telehealth reimbursement and getting CMS to acknowledge an MIH system. And so I often ask, what does it take as this becomes more and more popular? I mean, it takes a village, and it really takes finding a partner. And where our program is unique compared to a lot of the other MIH programs, they partner with hospitals. We partnered with our FQHC, and we have been told, as we talk to big folks in charting software world and others, that we're the first MIH model that partners ambulance with FQHC. And it just makes sense for what our goals are, is the primary care folks. If we were really looking at